you've been able to take clinical genetics and really establish this cycle of discovery where you're taking things from the bench to the bedside and back. Your work in Pompe disease has been incredible and has transformed the lives of so many patients and families. Can you talk a little bit more about some of the diseases that you've been studying and how you've really gone from bench to bedside and back?
Yeah, Swati, and I take a lot of pride in saying that, you know, people often talk about bench to bedside, and I can say that we as clinicians understand the importance of taking it from bedside also back to bench, and we've been able to do this successfully. And I can just start for a moment even with how the Pompe story emerged. I was in training at the time, and we had a patient with infantile Pompe, and this was in the early 1990s. And the only answer we could give families was, love your child, take your child home. There's not much we can do, and they're going to pass within a year of life. It was after returning from the funeral of one of these children that I think Dr. Chen and Johan Van Hove, who was a trainee at the time, said this cannot repeat itself. And that's when the team science started of how do we make a difference and make a change. And so that's my first message, is you actually need something, that brings you to work every day. And for me, it is the story of these patients and the unmet clinical needs. And so as we started this journey on Pompe, we recognized that with enzyme treatment, which Duke is known for, and we developed a treatment, but very quickly what I also learned was there are so many factors which are involved that we need to take into consideration. Very simplistically, even the immune response to a therapeutic protein is important. And I remember in the early days when I used to bring this up, there were some senior scientists across the globe who would not really agree to the message. And then it took me from bedside to bench, to show that this indeed does make a difference. And today we have what we call short courses of immune tolerance induction, which has made its way into the package label for our glucosidase alpha. So that was one part of the journey, and this has transformed the lives of those children who otherwise would have been deceased. The next step was also realizing that a few days matter. I started seeing that if you started enzyme therapy in a rapidly advancing disease, just a few days later actually could result in an outcome that resulted in either the ability to walk or not to walk. And so that took me back again to the concept of newborn screening. And so I advocated for newborn screening for Pompe, which is now on the recommended uniform screening panel and was the first lysosomal disease to make it on the panel. And today we have MPS 1, and I recently was part of the committee for submission for mucopolysaccharidoses type 2, and I'm proud to state that that's the other one now on the RUSP or the recommended panel. So I think this journey of crosstalk between laboratory science and patients has really allowed us to advance. And having put so much time and effort into one rare disease, I want to assure other families and other patients that have not neglected others, because again, it's the learning from one which takes you to the others. And currently we are focusing on other hepatic GSDs that have been passed off in the past, by myself included, in the general literature as benign. The reason we've called it benign is that maybe we've not followed these patients long-term, they're lost to follow-up, or there are silent findings at the level of liver, which then unmask as the patient gets older. And so our current focus is on some of the hepatic GSDs, like glycogen storage disease type 3, type 4, type 6, and type 9. And I think there's a theme that's emerging, that if you have storage material in the liver, you can end up with progressive liver fibrosis and cirrhosis and a risk for hepatocellular carcinoma. So this is currently an area of bedside to bench and bench to bedside, using animal models, both small models as well as larger models. We have canine models, which are naturally occurring that we've identified because we work closely with the diagnostic laboratory. And so we are able to use these models to help us understand what's going on and then put it back into patients and trying to see if this holds true. So that's the current focus. I'm very excited and trying to train the next generation of physician scientists, including some incredible grad students and undergrad students right from Duke, and some who come from UNC, just because they want to make such contributions to the field of genetics.
It's incredible, Priya, that, when you think about, you see a patient, you're informed by the patient, your emotions are informed by the patient, which led you to study Pompe disease. And, to be able to, in the cycle of discovery, understand mechanisms, develop therapeutics, influence policy, to be able to have newborn screening for Pompe and other diseases, and also training the next generation to continue this cycle. It's really incredible.